To all of you. Happy New Year to everyone, and welcome to the first session of this new year 2026. So, again, thanking all the people who make this program possible, Dr. Rakesh Gupta, Dr. Rohit, Dr. Vivek Sulere, who are always there, and of course, the Academy of Echocardiography Delhi NCR branch, which is always supportive. And so we have with us Dr. Rahul Mehrotra today, who is the Vice President of the Academy of Echocardiography, Delhi NCR. And he's also the Director of the Non-Invasive Lab, Artemis Institute, Gurgaon. And I know him for his very engaging presentations, and it's always enriching to listen to him. And today will be no exception. So you guys will really enjoy his presentation. But before that, I will take over, the first, the beginning, in the sense that we'll be dealing. Let me just share my slides and just a moment. Yeah. I-
Perfect.
Mhm. So I think now it's clear and visible, audible.
Yes, ma'am.
Yeah. All right.
Well audible.
All right. Thank you. So let me begin with, a very interesting topic of the dilated right heart, which is, generally given as step treatment, but it often, makes us stuck with the diagnosis that where are we standing. So today we'll be learning the echometrics before learning the differential diagnosis. And if we measure right, grade it right, we can decode it right. So I'm just, taking an opinion poll. You can send a yes or whatever, A, B, C, D. What is your most common trigger in the lab to assess when you see the RV dilatation? Why do you, what is the most common thing, which you use? Can you give your opinion?
A.
A. So everyone, why don't you just message? Let us understand honestly. Or you unmute and just speak out. It's mostly A or BCD.
A means just visual impression.
Visual impression. I
It's
think, yeah.
D, combination of parameters.
All right. So is this an honest answer, Dr. Ranjan?
Yeah, of course.
You
Of course.
use all the parameters.
Yeah.
Yeah.
We see
So,
RV-LV ratio mostly.
yeah. Okay. No, so the good things are right, but how often do we, measure the RV-LV ratio? That is the thing. Anyways, I just wanted to trigger everyone that it is not just the visual impression. We should move ahead now and know things better so that we can do it better in our routine eco practices. Wait. Yeah. So right heart dilatation is not a diagnosis. It's a measurement based on observation that demands context. So don't write right heart dilatation as a diagnosis. Find out why is it dilated. And now the guidelines on the right heart have come up after a long gap of like one was in 2010, 2015, and now 2025. So it emphasizes that use the please mute yourself, everyone. There's background noise coming, please. Reena, please mute everyone. So we first use the RV basal diameter as the primary metrics. Then the next step is, like, if the basal diameter is more than 41 millimeters or 4.1 centimeters, normally less than 1, I'll show you a table also telling that. So if the RV basal diameter is less than 41, it's normal. But if it is abnormal, then you will have further parameters to support your diagnosis of dilated RV, which are mid-cavity measurement, longitudinal measurements, RV-LV ratio, and then interpret the size with the function and the loading condition, meaning is there any volume overload or there is a pressure overload. Use visual plus numeric together and never visual alone. So this is the diagram I have earlier shown also on this platform. The RV-LV basal diameter ratio will measure the RV at the basal level, the LV at the basal level, knowing that LV is always bigger than RV. So this ratio is generally more than 1 at end diastole. Measure it at end diastole, suggesting RV dilatation. Take it in a 4-chamber view and avoid foreshortening to have false readings. Then this is also a major, common diagram wherein we know that the guidelines also say that whenever RV looks equal to the LV, it is dilated, whatever the parameters, whatever the readings are. So normally the RV is smaller, sorry. The RV is smaller than LV, 2/3 its size, does not form the apex. So when you will be looking at it, you will see that has the RV also started forming the apex? So that means it is getting bigger and bigger. Okay. So this is how it is categorized: mild enlargement, moderate, and severe. When it becomes larger than the LV and becomes the septum becomes D-shaped. So this is how you roughly keep assessing. Then these are the linear dimensions. This is a RARV focused view. All of us must learn in routine also, in normal patients also, that we make a RARV focused view so that it comes in a routine. And when we have to measure these dimensions, we do not face difficulties. So what are these dimensions which we are taking here? One is the longitudinal diameter, longitudinal parameter, and one is at the level of mid cavity, other is at the base annulus level. Okay, and all are taken at end diastole. So when it is the basal diameter when more than 41 millimeter, it is abnormal, and the mid level more than 35 is abnormal. The longitudinal dimension more than 83 millimeters, somewhere it is mentioned 84, 85 also. So roughly remember this. I'll show you a table. You can take a picture for easy memorization. So all these factors, all these dimensions are considered for assessing the dilatation. So that's what is written here. If the right ventricle appears significantly larger than the left ventricle, it should be reported as dilated. But remember, making a RARV focused view. And that holds true for measuring the RV functions also, like TAPSE and RVSV TDI. Now comes because this is the complete right heart dilatation we need to look for. It is not just the free wall or remember the geometry of the RV is very different from the left ventricle. The RV is in the form of a crescent, which is like, wrapping around the LV, and has three parts: the inflow, the apex, and the outflow, which are not in symmetry. So we need to see that which portion is dilated. We need to assess it at all levels. Hence the RVOT, which is the outflow tract, needs also to be measured. And I have earlier told also in this platform that the RVOT dilatation, anything more than 30 millimeters in the proximal RVOT, this is the Plaque's view. And in the Sachs view, when we are measuring from the RV wall to the aorta. How we are measuring it here? Everyone should look at it carefully. Normally, the LA, the aorta, and the RVOT, they are normally more or less equal in size. When this dilates, this will look bigger. And how do we estimate? See, RV wall to IVS aortic junction. Okay? Not like this. It has to be measured from this junction to the RV wall. So this is how we measure, and this is the proximal RVOT. This is also the proximal RVOT. Look at carefully the dimensions, more than 30. So in arrhythmogenic right ventricular cardiomyopathy, this can be dilated. All right. So if you will not measure, you would not know it. And in other reasons also, like whenever there's a pulmonary hypertension, there's a back pressure. So this starts dilating. So this portion also needs to be assessed, because we are today now talking about the dilated right heart, and RVOT is also a part of the right heart. And the distal RVOT, 27 millimeter and below is normal. And the PA, this is the, so normally what we do is in our routine practice, we measure PA, and we apparently visually see that is the PA bigger than the aortic diameter. So if not, then the PA size is normal. So the ratio of PA upon aorta is less than 1. Okay, but if it is dilated 25 and above, then it is called as dilated. So all these factors will help us in understanding that is it a pressure overload which is happening. So we need to measure all this: pulmonary artery, distal RVOT, RVOT proximal. And everything has a reason that, why this is being taught, because this will help us in reaching a differential diagnosis. Coming to the right atrium, what is emphasized in 2025 guidelines? Prefer RA area in 4-chamber apical view, measure it at end systole, index it to the body surface area, and grade the severity. RA size reflects chronic loading, not acute pressure. See here, this is how the area is measured. Disc method is preferred to the area length method. And the values, I'll give it to you. They also measure the major axis, the minor axis, and the values are here, more than 53 and more than 54. The RA area independently considered as more than 18 centimeters square. And this time the guidelines have also introduced for the first time the right atrial volume index like the left atrium. So we'll know the values very soon. And now moving ahead, let me, just a moment. This is disturbing me. Yeah, so eccentricity, we should also be knowing about the eccentricity index, which will help us, establishing that this dilatation of the right heart is because of pressure overload or because of the volume overload. So what is the normal eccentricity index? The diameter 2. Look at this. This is the LV and this is the RV. Okay, the LV cavity, the longer diameter is the D2 and the shorter is the D1, and normally it is less than 1. But what happens when the RV overload happens? It can be volume or pressure. The D sign appears. Can you see the LV cavity is now appearing D, and this is being compressed. The septum is being compressed. and the eccentricity index now is more than 1. The D2 is increased now. So let's see. This is the RV pressure overload, in which you see that in both systole and diastole it is D-shaped, okay? And it is the index is more than 1. D2 is more than D1, markedly more than D1. So the D sign is present both in systole and diastole. Please mute yourself. So we see that the RV pressure overload, can you see this right ventricle? It is dilated. Now it is even bigger
Yes,
than
ma'am.
the left ventricle. And the pressure is pushing the septum towards the left ventricle, hampering the left ventricular output as well. Remember that. And here also in diastole, it is happening. So when it is present both in systole and diastole, we say it is dilatation because of the RV pressure overload, because there are causes for that. Okay. So you need to actually categorize that. Okay, now it's dilated, now it's pressure overload. Now what is the reason for the pressure overload? Now this is RV overload, wherein you can see that in systole, this round thing septum is maintained and the eccentricity index is normal. But what happens is in diastole, the pressure pushes due to the excessive volume, it's pushing the septum towards the LV cavity and it forms a D. So here the eccentricity index becomes abnormal only during diastole. So you need to understand the physiology so you will not have to cram it. And that's why I made this, inserted this schematic diagram so that it imprints in your mind and you do not forget. So this D sign is important to register. So, the right ventricle is a chamber which is thin, which is crescent shape, does not take so much of pressure, and the pressures inside are also lower than the left ventricle. So it's much, much different from the left ventricle in its behavior also. So whenever there is a pressure overload, it thickens the RV. So what is this statement saying? That whenever there is a chronic pressure overload, not in the acute state, the RV will be hypertrophied. So you need to look at that also. Whenever there is an overload, it stretches it. This heart actually, right heart is, it adapts itself very well to the volume overload, but cries very early and loud to the pressure overload. It can't take the pressure, though it can take volume much easily. So it said RV is built for flow, not force. And another tip is right heart must be interpreted in the context of volume status, the TR severity, and the pulmonary pressures. Because you can't just be interpreting as per the dimensions. You need to put everything in a context. And also, of course, the IVC is an important part. The dilatation of IVC, the collapsibility, that is also to be interpreted in the context. So I'm telling you all this because now in the next presentation, you'll be now, thinking that, yes, what did I get? And what am I looking for now? So again, I'm saying the context is very important. It is not that just that you have diagnosed that the right heart is dilated and that's it. You need to find out why is it dilated. So just few pearls, although Dr. Rahul will be telling you all this. So is the, you'll see, is the RV dilatation proportionate to the pulmonary pressure? Yes, think in terms of pulmonary hypertension. If no, think shunt or volume overload as the cause to it. And apply this wisdom pearl now after this in the Dr. Rahul's presentation while he'll be showing cases, and this will make you much better in knowing that what is the cause. High pulmonary pressure, think that probably you're dealing with a pulmonary hypertension. And no raised or mild pulmonary pressures are raised, think in terms of shunt and volume overload. So this was the table I was talking about, taken from right heart ASC right heart guidelines in 2025. So see the RV. So let me just tell you in brief that this this guidelines said that instead of one single diameter, it is better we grade the situation or grade the dimension, and this will help us in risk stratification of our patients, and also to estimate and follow up the disease severity or the impact of the therapy. So they emphasized on the grading this time more than anything else. Most of the things were there before, the RV basal. Okay, you can take a pic of that, or this is also available on the net, and you can stick this in your Ecolab for better reference. So they have graded it into mild, moderate, and severe, saying that you can be more capable of risk stratifying your patient. That is the disease very severe, you need to be very quick and targeted. The RV wall thickness less than 5 is normal, and more than 9 millimeters is severe. The RA area I have said. Then the introduction of right atrial volume index. So they prefer method of disc, but they say that if area length method is used, is not there, with your machine, you can use this method also, but they should be indexed anyways to the body surface area. So you will be, feeding with the machine with the height and the weight of the patient. Then the pulmonary artery diameter is also given importance in the structure severity grading. As I said, 25 centimeters, 25 millimeters below, and then more than 35 millimeters and above is severe. Okay, let's understand who all says what. Can RV be dilated with normal pulmonary artery pressures? Say yes or no or C. You can unmute yourself, and instead of chat, you can tell me what do you think? Can it happen? Can RV be dilated with normal PA pressures? I just want to know how much you have learned.
Yes.
Dr. Tandon, please see that what people are saying. Are they chatting or not? Okay, so let me answer. Okay. So, oh yeah, a lot of people have chatted. Ranjan,
Now, ma'am, suddenly a lot of responses are coming.
yeah.
Ma'am has asked a very relevant question. RV is dilated, but PA pressures are not there also. Then there has to be something. We have to search for the cause. That was the main thing.
Yes. So Dr. Rahul will highlight and emphasize more on that. And we keep this question still pending. But yes, you're right that the answer is yes. Remember that. Okay. So.
Ma'am, yeah. So all three.
No. What are they saying?
Ma'am, they are saying C.
Okay.
And what? Yes, C. Then that's all. Yes,
I
and
hope
C.
B. Nobody is saying B.
Nobody has said B. Fortunately.
That's great. So both the answers are right. Yes, it can happen, and usually happens due to volume overload. So let's also understand another question. Most common cause of isolated RA dilatation in practice, what you see in your practice. Most common cause of isolated RA dilatation in your practice. A, B, C, D. let's ask our moderators and Dr. Rahul, Dr. Ranjan, what do you have to say?
Pulmonary hypertension.
Do you find it so often as a cause of isolated RA dilatation?
Most of the time, TR.
TR would be
Yeah.
the answer.
Yeah, correct. So
Secondary
TR,
to left heart disease mostly. Secondary to left heart disease, tricuspid
yes,
regurgitation.
yes. Good, great. So now our question shifts. We were, till now we were handling the question, is the right heart dilated? So we have understood that yes, the right heart is dilated. Now, why is it dilated? And it's now time to decode the cause. And over to Dr. Rahul Mehrotra to help us decode the causes and how we can approach such patients. Over to you, Dr. Mehrotra.
So, thank you so much.
I will just stop sharing my slides.
Yes, please.
Yeah, I did that.
So am I allowed to screen share now?
Yes, please do that.
My screen is visible.
Yes.
So thank you so much for laying the foundation for what is to come. And I hope the viewers will be now more accepting of my presentation and they will understand it in the right context, because you already explained, starting from the question, that it is no longer subjective. The right heart assessment is very much objective now, and we should all include these parameters in our memory now. If not memorizing, we should hang these charts in our labs. So report according to standard numbers given by the guidelines, and based on that, we should be reporting about right heart, because right heart has been ignored for a long period of time for no fault of its. Medicine was all obsessed with left heart. It's like a bhed chal in Hindi. Like
Yes.
everybody is into intervention, everybody was into left heart evaluation, huge amount of data. But now we have started looking at right heart also. There were certain problems also other than the following the crowd. The reason is that the right heart is a very complex shape. It is a teapot shaped structure, inflow, outflow. There is a broad inflow, and then there is a outflow tract very close to it. So, typical structure. Most of it is hidden behind the sternum, and also it is heavily trabeculated right ventricle, particularly in the mid part. So, all these made images challenging. So, we gave up on collecting data and evaluating right heart. But last 15, 20 years, there's been continuous development, very rapid development, I should say, in terms of evaluation of the right heart. Our older presentations had dilated right ventricle mentioned as when it is greater in size than left ventricle, it is supposed to be reported by eyeballing as dilated. No longer so. 2010, and as Dr. Hansa mentioned, updated chamber quantification guidelines, right, as well as left, came in 2015. American Society of Echo, but also endorsed by European Association of Cardiovascular Imaging and also Indian Academy of Echo. And more recently, we have the 2025 guidelines, again further moving ahead with more data coming up, more normative data coming up for right heart evaluation. And we have now indexed values for males as well as females for subparameters. And we have also now a classification of mild, moderate, severe, which is again latest. The older presentations of mine even did not include mild, moderate, severe because we did not have these cutoffs. So now a comprehensive quantitative RV evaluation should be part of routine echo study, taking into account the indication for which echo is being done. If you look at the older reports from even the premier institutes of cardiology in the country, there will be no mention of IVC and there will be no mention of right heart parameters. But now the guidelines say that there should be at least one RA parameter, RA size, and one RV parameter of size, and RV function along with RV systolic pressure, if TR is there, should be incorporated in the normal echo reports of all patients. Having said that, more detailed evaluation of right side should be done if there is a pertinent indication towards looking at the right side in greater details. So Dr. Hansa has already mentioned about different views we look at. So more commonly, it is about training our eyesight. We are so obsessed with looking only at the LALV that commonly in all labs, we miss out on looking at RA and RV. And if you don't look at right side, you will not appreciate an abnormally dilated right atrium or right ventricle, and then you will not undertake a detailed evaluation. So this is the apical four chamber view. These are very obvious images of abnormal right heart where septum is bouncing, cooperating with the right ventricle rather than with the left ventricle, which is normal. You can see the short axis view where septal shift is occurring, a very detailed explanation by Dr. Hansa. You can make out looking at this whether there is predominant pressure overload or volume overload or both. If you look at this septal shifting or D-shaped left ventricle, and then AP and septolateral diameters are taken. This view very commonly we ignore to take the RV inflow view, just tilting our parasternal long axis view towards the right side to make an RA-RV inflow view. Very useful view in most studies, and particularly if you don't get a good TR jet in any view, you can align your leaf in this view and you may find good TR jet, which is also aligned very nicely with the beam for continuous wave for measurement of PA pressure. Also, you can see the septal leaflet of the tricuspid valve better sometimes in this view. So a rule to remember other than the tips given by Dr. Hansa are the right heart dimensions. We should know the views and the values. So she has given both the typical views that we make, the short axis basal view, which we look at for TR only, but also look at RVOT. Very commonly congenital anomalies, ARVD, etc. will first pick up in this RVOT area of the right ventricle will get abnormal. So in each of these different views, you get to see only a part of right ventricle and a different part of right ventricle. So we should get into the habit of utilizing all these different views for looking at RV. For example, in this plaques view, we see a part of RVOT. Inflow view, we are seeing the anterior wall and the inferior wall of right ventricle. A distal RVOT and a proximal RVOT both are seen in the basal short axis view incorporating aorta. This is the free wall of right ventricle, RV in the form of a crescent, normally seen in patients when we make a short axis view at the papillary level. Four chamber view, Dr. Hansa has already shown you how we can measure the long axis, the basal RV diameter, and the mid RV diameter in these views. Another view is the subcostal view, which gives a very good orientation for the free wall of the right ventricle and the interatrial septum, which is if you want to evaluate. An important concept which was brought out earlier again was
Dr.
be the
Rahul, I'm
habit of making.
just interrupting. Can you just go back to that subcostal view? I think this is a good view to measure the RV free wall
Yes,
thickness.
very importantly, RV
Yeah.
free wall thickness is measured in the subcostal view. The recommended view is this at the level of the opened tricuspid leaflet when it opens in diastole, where that will suppose to hit, suppose here. Zoomed view at this level, and we should report RV thickness in terms of millimeters exactly at this location so that we have standardized reporting and not just somebody measuring somewhere else, somebody measuring somewhere else, getting discrepant values. So this is
All right.
important view for RV hypertrophy, RV thickness measurement.
Hmm.
So all the measurements of right ventricle, right atrium should be taken in the RV focused apical four chamber view. This is a very important concept which was brought out in 2015 guidelines, and now much more detailed emphasis is given in the latest 2025 guidelines. So RV focused view is nothing but tilting our four chamber view in such a way that LV apex remains at the center of the sector, yet the RV basal diameter becomes broader. If you can see the difference between these two images, you will be happy accepting this image and you will start measuring in the upper image because you are seeing RV. But what you are seeing is a foreshortened RV. And what you have to do is tilt your probe in such a way that you get a basal diameter of RV, which is the maximum. As compared to the upper image, you can see the basal diameter is now much more wider, and LV apex remains in the center. So this is the correct RV focused apical four-chamber view, and this is the view in which the values, the parameters which Dr. Hansa had earlier shown, should be taken. The RA and the RV should be measured in this particular view. So we should all practice making this view. This has already been shown, the normal value, the volumes for RA now available for males and females separately, index to body surface area. For some other, we still have single numbers across genders, across body surface area. But as we progress, as more normative data becomes available, surely we will have these values also for other parameters. RA volume calculation by area length or by Simpsons in a single plane four-chamber focused view is what should be done, not biplane, which is not applicable to right atrium. And based on that, we should be reporting the RA volumes. I won't go into these details. Just a word, it is important to, why is it important to measure these dimensions and give these numbers very objectively? Because these sizes correlate with prognosis in several different diseases. For example, in pulmonary hypertension, you will be, probably you know, that RV pressure, RV systolic pressure is not a prognostic marker, but RA area, means RA size, is a prognostic marker. So if a patient has PA pressure of 120 and RA area is theoretically not so much dilated, but in a patient with PA pressure, say only 80, but RA area is very much dilated, the worst prognosis is going to be in this patient who has a dilated RA area. So it is a very important prognostic marker, sensitive marker of diastolic dysfunction of the right side. So RV hypertrophy, for example, if you have a patient of hypertrophic cardiomyopathy on the left side, but you have reported also presence of RV hypertrophy, then for all the same parameters, the prognosis in this patient is going to be worse. So it adds a lot to the clinical information that we are getting if we incorporate these parameters of size, hypertrophy, function in our echo reporting. So coming to the topic assigned to me, the differential diagnosis of various causes of RA, RV dilatation. You have picked up dilated RA, RV, but what will you think of as the cause after that? And based on that, you have also to evaluate the suspected cause of the RA, RV dilatation. It is not enough to just report that it is dilated and stop at that. Whenever you are finding it right heart to be dilated, you have to suspect a cause. And there are different ways of classifying. One of ways was shown in a question by Dr. Hansa. You can call it the volume overload or the pressure overload. You can classify it in terms of congenital and acquired causes of right heart dilatation. So any way which you want to remember, it is good to know these various causes which result in right heart dilatation. ASD, partial anomalous pulmonary venous connection, coronary AV fistula, extracardiac shunts, Ebstein's anomaly. These are common congenital anomalies. You can also add carcinoid heart disease, etc., which are quite rare. Uhl's anomaly, rare causes, but this is a list of common conditions which we should suspect and rule out in our patients. Left-sided heart disease like rheumatic heart disease, mitral stenosis, mitral regurgitation, dilated cardiomyopathy, left heart failure, all these will be common causes in our scenario of giving rise to right heart dilatation and also dysfunction. Atrial fibrillation will result in biatrial enlargement. Right atrium will also be dilated along with left atrium. Pulmonary hypertension is a disease entity which will cause right heart abnormality. So let's move to the interesting part. Rather than verbatim lecturing, making you scared of remembering so many new numbers of the right side also, other than already having to learn the numbers of the left side, let's move to interesting images of dilatation of right heart and trying to figure out the diagnosis of dilated right heart. So this was a patient from Africa, came to us with history of progressive dyspnea on exertion for the past 2 years, now leading to orthopnea. Chest X-ray in her country had just told her that her heart is enlarged and she should see a heart center and get further treatment done. So this was the first echo image, which we look, the conventional first view, parasternal long axis view. You can see anybody, which part of the right ventricle is dilated in this? Please unmute and speak out.
Proximal part, sir.
So what you see in plaques is RVOT. So
Yes,
RV
sorry,
outflow
RVOT.
tract is seen, and we can see clearly that the RV outflow tract is ballooned out, clearly dilated. So LV is not dilated, paradoxical septal movement, but RVOT is dilated. Anything else you can diagnose from this picture? You've forgotten to look at the left side, only looking at the right side. Common, you can easily.
Mitral
There is
stenosis.
Very good.
Mitral
elevation
stenosis.
So there is mitral
MS is there.
stenosis, there is LA enlargement, there is some pericardial effusion, but MS is very apparent. So immediately we know probably this MS is the cause of RV dilatation. We will also have RA dilatation. So first image, and we have already concluded if we have a thinking mind with a background knowledge in us. So further images, just for your information, clearly mitral stenosis, small amount of mitral regurgitation, mitral stenosis confirmed in this short axis view. More pericardial effusion is visible here. Probably this patient has significant right heart failure, pressure overload causing pericardial effusion also. Further imaging revealed this image. So you can see RA is very much dilated. Tricuspid leaflets are non-coapting. There is expected to be severe tricuspid regurgitation, which is clearly present. So a patient with severe mitral stenosis will tell you the area, etc. also, but severe tricuspid regurgitation also, dilated right atrium, dilated right ventricle. But having listened to Dr. Hansa, we will not stop at just calling it dilated. We will have to report now number also. So RV basal diameter we have measured is 4.1 centimeter. In RV focused apical four chamber view, it was supposed to be less than 4.1. Ours is 5.1 centimeter. RA area we've calculated 35.9 centimeter square. Normal is less than 18 centimeter square. Grossly dilated right atrium. RV systolic pressure has been calculated by continuous wave Doppler, and it is TRPG is 76 millimeters mercury. We will add RA pressure based on our IVC
Dr.
size
Rahul,
of collapse.
again interrupting for the audience. Just go back to your previous slide. Now we are seeing in this TR Doppler trace that there are a lot of variation due to respiration.
Yes.
All right. So what should be the actually calculated velocity? Is it an average or what is the rule? Can
So
you
if the
please tell
patient
the?
has
Yeah.
atrial fibrillation, we should have an average of 5 values.
Yeah.
But in this patient, the patient, you can see the ECG tracing. A patient is in sinus rhythm, and this is
Yes.
primarily respiratory variation. So we've calculated the maximum pressure that we are getting, and
All
not
right. So
an
nothing to do
average
with
because
the
of this reason.
inspiration or expiration.
So that is a question for the audience, I think. Where will the right atrial pressure be maximum? Will it be with inspiration or will it be with expiration? The right heart inflow increases with inspiration or decreases with inspiration?
Increases with inspiration.
So the flow will be more and hence the pressure will also be more in case of inspiration. So this is, you can take it as the inspiratory pressure that we measured. Am I right, Dr. Hansa?
Yeah. So just wanted to tell because if it is a sinus rhythm issue, you will be averaging it. But if it is because of the excessive respiration, a person is very dyspneic, then you may find such kind of varied, velocity difference. So this diagram this panel was showing very nice things. So I just thought, let me point it.
It is imaging for today itself, and we had this patient is today.
Oh, aha,
So,
acha.
mitral stenosis, planimetered. We have more images, but in the interest of time, I just focused here. Area calculated was 0.7 centimeter square. Planimetered area, both commissures fused, clearly fish mouth appearance, severe mitral stenosis. So here, an interesting scenario. The right heart is dilated, and this is a common scenario to look at the right heart abnormality, usually because of left heart abnormality. In this case, rheumatic mitral stenosis causing severe, significant enlargement of right atrium. Now I can use the term severe also based on criteria shown by Dr. Hansa in the latest guidelines. So TR is also severe. And what would be the cause of tricuspid regurgitation? Is it only because of MS, or we can see some rheumatic thickening of the tricuspid leaflets also being shown, which is causing this significant TR. So this is just a thinking cap. We should always be having these questioning attitude to look at this tricuspid image. Is it tethering and non-coaptation because of the significant pulling apart of chordae, pulling apart of the annular dilatation that is happening because of RA and RV dilatation, which is causing non-coaptation and high pressure TR? Because it was a high pressure TR and no significant forward gradient was noted, we concluded that this patient does not have rheumatic involvement of tricuspid valve, but it is primarily because of severe MS on the left side that this kind of situation has resulted. Coming to the next clinical scenario.
Rahul, I think I have muted you. Sorry, please unmute yourself.
Okay.
There were a
Coming
lot
to
of
the
disturbances.
second case scenario, I think the diagnosis is very apparent, but commonly missed out. This patient came to us for TE because echo done outside had reported a dilated right atrium and right ventricle on transthoracic echo and left it at that. No cause had been found. So we straight away took for T, although we knew the diagnosis on our transthoracic imaging also. I'm sharing with you the T images. So 36 years old lady, routine health check, reported to have RBBP on ECG and dilated RA-RV on echo, and the health checkup stopped at that. So we did a T. Clearly, the patient has atrial septum defect, secundum type because the primum septum is intact. We can clearly see an atrial septal defect, an RA and an RV which appear bigger than LA and LV, but we will measure them, and we will also measure the defect size. In this case, the other rims which we examined in the transesophageal echo, we can see there is a secundum atrial septal defect. We'll measure all the rims, and we also measured the TR pressure in these patients. The pressure gradient was 21 millimeter mercury RV systolic pressure plus IVC pressure, which will be added. And these are the 3D images. Again, from the right heart evaluation is also can be complemented by 3D evaluation now. And for different indices, we also have RA volume, RV volume, which can be calculated by 3D now and reported. So these are 3D images of this patient showing the discrete atrial septal defect from the right atrial perspective. This is the true view showing the shunting happening from left to right. Beautiful images clearly demonstrating RA area. Atrial septal defect size. By 3D echo, we can also measure the atrial defect size diameter and also the perimeter of the defect size. So it is helpful for the interventionist to decide about the device which can put in. So the diagnosis would be in this case straightforward. Secundum ASD, all rims adequate, left to right shunting, dilated RARV. Again, we should not stop. In this case, the health checkup, it was done in a lab setting where comprehensive health check is done and ECG echo is also done. So they stopped at reporting RA and RV dilated, but did not report upon the cause of RA RV dilated, which required further evaluation by transesophageal echo. Although a subcostal view had clearly shown to us that there was an ASD, but for an ASD, we should always do a transesophageal echo for getting correct dimensions of rim and correct size of ASD, particularly in adult patients where transthoracic subcostal imaging is not enough for making a complete diagnosis and decision making for the further treatment of this patient. So I think this was just an enlightening slide. Moving with another case scenario. Here we had a patient who had a history of ventricular arrhythmia, was being treated by our electrophysiologist, and had also received an ICD. I think already you know the diagnosis. Anybody would like to speak out? Rare rhythm disorder,
ARVD.
ARVD is the diagnosis in one go. So, emphasizing that we should always look at the history. So, I know the patient has been referred by electrophysiologist, the patient has an ICD in place. Still, if I look at ejection fraction 50-55% report and forget about it, I would be making a grave mistake. So, once I thought about a young patient receiving ICD coming from an electrophysiologist for an echo, I suspected dilated cardiomyopathy, of course, but also thought of this rare rhythm disorder. And clearly, in the first view itself, if you look at the parasternal long axis view, you can see that the RVOT in this case is very thin and of almost bulging outwards. So this is the area which is commonly involved in the triangle of dysplasia, which is reported in ARVD, and one of the areas where you commonly find thinning replacement with fibrofatty tissue in ARVD is this part, RVOT, along with the other areas included in the triangle of dysplasia. If you look at the apical four-chamber view, ICD lead is seen, but you can also make out the apical part of RV is dysfunctional. Although if you measure TAPSE, you will see that the TAPSE was normal because the basal part is moving normally. But this is where we have akinesia. So we should not be sticklers to numbers and just views. TAPSE is normal. How can RV be abnormal? You know the limitation of TAPSE. You are seeing motion abnormality in the apical part, clearly akinetic apex. So we should report that. And the likely diagnosis is ARVC. So we made an RV inflow view in this patient. You can see this is an inflow view, the RA and the RV. The RV anterior wall is completely akinetic and ballooning out. So typical diagnosed confirmed case of ARVD even with MRI, which presented us with beautiful images of ARVD for presentation like this so that we can learn how ARVD, RV thinning happens, how ARVD causes RV dilatation. Further zooming of the image, you can see microaneurysm formation bulging out of a small part of RV wall, clearly demonstrated here in this apical view. Again, this view clearly showing bulging out of a small part of RV happening. So unless you are suspecting this and looking at different parts of RV by zooming the image one by one, all parts of RV are included, you will be not be able to pick out these abnormalities. This is a gross clear example of a known case. But if you are suspecting ARVD, look at these views, zoom your images, and look out for ARVD microaneurysm. 3D echo also brought out this aneurysmal bulging very nicely. Orthogonal views also demonstrated the same abnormality very nicely. RV basal diameter was increased 4.3 centimeters in this. RV dysfunction, because we are measuring tissue Doppler dysfunction only at the basal part, almost normal, less than 9.5, abnormal, but just about, but there is gross RV dilatation. So that's why we did not stick to these values. We also went ahead and did RV free wall strain, which is severely reduced because the free wall, rest of the free wall is almost not moving. You can see basal part moving well, but the mid and apical part almost akinetic in this. Free wall strain significantly reduced. Normal should be more than 18. TAPSE even better, but free wall strain significantly reduced. We can also do RV and RA volumetric analysis now. If you have these softwares for RA, RV volume, we can see in very little time, very accurately, we get RV end diastolic volume, end systolic volume, stroke volume, and even RA volumes are now possible in the newest software. So wherever available, we should incorporate these, measure these values if we have enough experience with doing this kind of analysis, and report a comprehensively based on our findings, not sticking to just linear parameters, because we have evolved in right heart. We have moved to volumes now indexed to body surface area, and they should be incorporated in our reporting. Another case scenario, a congenital combination. The patient told us that he knows since birth he has a heart condition, 40 years old male. He's grown up to 40 years of age. No intervention has been done till now. But now he has been becoming symptomatic on routine activities also. X-ray always shows cardiomegaly since childhood. And on auscultation, we found multiple heart sounds, split first and second heart sound, and a pansystolic murmur varying with respiration. Anybody can give the diagnosis at this stage. Fastest finger. 1, 2, 3, 4.
VSD?
Ebstein anomaly.
Wonderful. Who was that?
Dr. Ranjan Kumar.
Dr. Ranjan, Ebstein's anomaly is the right answer. So, commonly seen in adult patients, adult congenital heart disease is what we call it. A congenital heart disease which is compatible with survival up to longer years. So, patient has survived up to this year without any intervention being done. Multiple heart sounds, as many as 7 heart sounds are heard in typical patient of Ebstein's anomaly. But in this patient, an interesting clue is there is split of second heart sound also. I'll come to that later. But let us see in this again plaques view, RVOT clearly dilated. We have RV dilatation on the cards. So we will evaluate this patient in more detail towards the right side. We will be focusing our eyesight towards the right side also. You can see in this 4-chamber view, the mitral leaflet and the tricuspid leaflet are inserted very differently. The tricuspid septal leaflet is more towards the apex as compared to the septal or the anterior mitral leaflet. There is distance between the septal insertion of the mitral leaflet and the tricuspid leaflet. There is significant PR clearly noted in this patient. So we measured
Please
the
mute yourself. Audience,
septal
please mute
tricuspid distance
yourself.
also.
Rahul, I'm muting everyone. You just again unmute yourself.
Yes, yes, ma'am.
Please unmute yourself, Rahul, now. Yeah.
So these are other views. We have to measure the distance between the mitral and the septal tricuspid leaflet. Here it is 15 millimeter. TR is low pressure TR, not very high pressure. But interestingly, in the subcostal view, you also see that there is a shunting happening from left atrium to right atrium, and there is an associated ASD also. So the lesson from this is that we should not just jump to conclusion that okay, I found the cause of right atrial dilatation in my patient. It is RV dilatation. It is because of Ebstein's anomaly. There can be a combination of congenital heart diseases which often go together, and this is Ebstein's is associated with ASD in our patient, both giving rise to significant dilatation of right heart. So this was the final diagnosis: Ebstein's anomaly with secondum ASD resulting in dilated RA and RV. So the common bottom line in our patients has been dilated RA and RV, and we have seen so many different kinds of dilated RA and RV with varying kind of diagnosis. The useful concept is to look at the history always, have the background, and then let your mind into thinking into the various DDs. Start with the commonest possibility, left heart disease, then think of the rare possibilities like Wool's anomaly. I'm yet to see an Wool's anomaly patient in my lifetime. I've not seen a presentation on Wool's or any image of Wool's anomaly from anybody in any forum till now. So we should not keep these possibilities upfront, but common possibilities should be kept before we think of these rare possibilities. Here is another common scenario. Again, a relative of mine, 42 years old radiologist, had a syncope a day ago, came to us for echo. Routine health check 1 year ago was normal. What we commonly have in routine health check is lipid profile, HbA1c, kidney function, ESR, and CRP. And if all that is normal, we assume everything is fine with us. But echo reported a dilated right atrium and right ventricle. And if you can see in this one slide, the RVSP measured is a dense continuous wave jet, truncated at the top, not prolate ellipsoid. PG reported is 119 millimeters of mercury. Syncope 1 day ago, blood evaluation 1 year ago, normal. What can you think of?
P. Pulmonary embolism.
Why not pulmonary hypertension?
Pulmonary hypertension, yes.
Either radiologist has a sedentary lifestyle, goes from clinics to clinics, doesn't work at all, no exercise. He has been
Syncope.
sitting and while doing radiology, he had syncope. So could be pulmonary embolism, yes, but pressures are so high. Why not pulmonary hypertension? Clearly, the first diagnosis, not by Dr. Hansa, but by us, was the patient has severe PH. Our diagnosis is confirmed. But we made this basal short axis view, tilted it upwards. Pulmonary artery is seen, pulmonary artery bifurcation is also seen. And what we could see clearly was right pulmonary artery completely filled with thrombus. So yes, pH, but because of acute pulmonary embolism, which gave rise to this very high pulmonary pressures. So this is not chronic pulmonary hypertension. This pulmonary hypertension resulting from acute pulmonary embolism, and we can even demonstrate right pulmonary artery thrombus in this particular patient. So RA-RV dilatation with syncope, think of pulmonary embolism, pulmonary hypertension. Look at pulmonary artery bifurcation in most of your patients. Sometimes you will find thrombus here and the diagnosis is already made. So a very good scenario to pick up by echo. Usually we do not go this far. We do not look at these very clearly. We measure the pulmonary artery here and we stop at that. But try to make a habit of looking at pulmonary artery bifurcation also. You will not miss out on this diagnosis. Do we have time, Dr. Hansa? This is my last case. Or
Yeah,
I could skip.
please go ahead. Dil mange more.
Okay, thank you.
Yeah.
So
I think
this was
everybody is agreeing with that.
Yes, ma'am.
Yes,
Yes.
agree,
Yes,
agree.
ma'am.
Yes,
Yes,
ma'am.
ma'am.
Yes, yes.
okay.
Yes,
Then
See,
this is
see,
a case scenario for you. I think there is a prize from Dr. Hansa and JROP to whoever gives an answer to this particular scenario. Call from ICU came. Patient was recovering well from a spinal surgery, was ready for discharge, but has developed breathlessness, and they cannot shift him to room because there is tachycardia on the monitor. ECG is showing sinus tachycardia, and our bedside echo machine went there. We did an echo. Again, Plaque's view, first view giving us the clue. In all the images you have seen, Plaque's view gives us the clue. RVOT dilated. LV appears normal. The patient had been given pre-op clearance based on a normal study. But RV inflow view, anybody diagnosis quickly?
isn't the RA showing an embolus in the
Yes.
inflow view?
No surprise to the audience, Dr. Hansa keeps from.
Uh,
You can see
Yeah,
a
yeah,
thrombus in transit.
Pulmonary embolism.
This earthworm-like structure moving
yeah.
around in RA. So this is thrombus in transit. So we have caught the scenario in the previous case. We had seen a pulmonary embolism which was already happened. Here we are seeing a pulmonary embolism happening live. So this is a thrombus cast in the form of deep vein leg veins, a long elongated thrombus cast of the deep veins traveling from RA to RV. Part of it has already traveled to pulmonary circulation, causing pulmonary embolism. That is why the patient has RV dilatation already, but it is still in transit. So there is thrombus in transit. Pieces of thrombi can be seen clearly in RA. So a very interesting scenario where we sometimes are able to capture pulmonary embolism happening live. Short axis view again showing the septal shift pointed out by Dr. Hansa. RV is not crescent shaped. RV is much more bigger in size than LV. Septum is being shifted towards this side. And in this view, again, you can see this moving around of a thrombus burden in the right atrium across tricuspid valve. It is prolapsing into right ventricle already. Pieces have already broken and gone into the lung circulation. So this is more embolism waiting to happen. IVC view, again, we can still see some thrombus left in IVC coming from the deep veins, further embolizing through the right heart, causing pulmonary embolism. TAPSE will be normal, TDI in this case normal. So one more question. Anybody can tell me what is being shown in this? What is this known as? PA pressure 45 millimeters mercury, and this is RVOT acceleration time or pulmonary artery acceleration time we've measured.
They have been
keeping the
shown this case
cursor.
earlier on this platform only, so they should be answering this.
So there is a
This
notch
panel.
and dome pattern, and acceleration time measured is 36 milliseconds. 45 millimeters mercury, 36 millisecond. What is this?
60-60 sign.
60
sign.
So who said that?
Again, Dr. Ranjan.
Oh,
And
Dr.
another girl, who is that?
Dr. Richa, ma'am.
Okay,
Yeah,
Dr.
Dr.
Richa
Richa.
ने तो ये केस किया है. She will not get this prize. So this is 60-60 sign. Again, a very useful sign as far as they say, if both these are present, the specificity for pulmonary embolism is almost 100%. So if you have this kind of acceleration time reduced less than
And
60
the mid
milliseconds,
systolic notching also is
and
there.
this notching very
Yeah.
clearly visible, then you can be almost sure that there is pulmonary embolism. But pulmonary embolism happening in the case. So to summarize, RV has a complex morphology, no doubt, but we are moving towards better evaluation, clear numbers being given by guidelines, clear cutoffs being given. Echocardiography is the best modality for looking at RV abnormalities. So we should include our right heart evaluation in all our echo reports. It gives a clue to the diagnosis. Not only that, it adds to the prognostic value of even left-sided heart diseases, and we can use it for looking at the response to therapy also. For example, in pulmonary hypertension patients, if RA size is regressing, it is a very useful marker that the patient is improving. So there is no option now. We will not look at right heart only when it is abnormal. Right heart should be evaluated in all studies using all available views. And over the course of this presentation, we've seen the different views, the different scenarios. Earlier, Dr. Hansa has already told us about the different measurements that we should be taking in the RV focused views to give clear numbers to our parameters for dilatation, dysfunction, etc. But there are certain limitations compared to the left side, which is the blue-eyed baby of the heart. We all are left side heart experts, but very few right heart experts. The current values are not indexed to body surface area. You saw clear, straightforward numbers. You may be a 6 foot taller or a 4 foot person, the same criteria are applied. So that is a limitation. Gender specific values are just emerging for some parameters only. Mild, moderate, severe is not always possible. We have numbers now with the new guidelines Dr. Hansa had shown, and there is a need to generate more robust data with more normative data being generated, particularly from our country. So, a message: let's start doing right. Let's start looking towards the right side of the heart, avoiding the left side also. And this is an important platform. I encourage always to join the Indian Academy of Echo. More such academic meetings are happening, and where you can increase your learning. With that, I'll end the presentation, and there are any questions we'll have. But I think we'll move towards the presentation now, Dr. Hansal.
Excellent presentation, Dr. Rahul. You have actually enriched us. It was very, very engaging, and I'm sure, nobody must be sleeping and wanting more and more of it. Fantastic. I would say simply fantastic. Okay, a lot of cases, and see now a lot of, thumbs up are coming for you. Okay, so everybody is very, very
Thank you.
happy for the cases you have shown. And before the question comes, I have one question, because in the beginning, you see, a lot of thumbs up are coming for you. Great, guys. This is actually motivating. Very nice, very nice. Good, good. Keep it up. We need to motivate such speakers.
I think these thumbs up is for the right heart.
Yeah, but how the right person has presented the right heart, that also matters.
Thank you.
That also matters. Very good. See, a lot of appreciation. Excellent.
The
Excellent.
reason is that
So
the left heart is always
yeah,
so, the big shots will always be talking so much about the left heart. So
yeah,
the right was left for me.
yes. No, for all of us, for all of us. And so, but I would say, our audience is actually very, very motivating.
Yes.
They are big enthusiasts, and that is why, this kind of response is coming, right? So I would ask you one question. You said in the beginning of your presentation that
So I think Dr. Rakesh is ready for presentation.
no, but I have to ask you that question.
Okay.
Yeah. So you said that, we should be giving some parameter pertinent to the RA, RV in our reports. Okay. Now IVC, of course, has been, continuously being reported now by majority of the people, IVC and its collapsibility. But we do not mention any diameter related to, of course, TAPSE is being reported, RVSV TDI is reported, but we do not measure any RA, RV until and unless we are finding it to be visually dilated. So is there any recommendation, or do you
Yes.
suggest? Tell me
So
about
right
that.
heart guidelines mention clearly that in all reports, we should have at least one parameter of RA size, preferably RA area, because it is very
RA
easy to
area.
measure.
Okay. Okay.
One parameter of RV size,
RV,
like
and which
basal
should be
RV
that
we can measure,
basal RV. Okay.
and one parameter of at least RV function. We are using TAPSE, most of us in our labs.
Yeah.
But if we find any RV abnormality, then we should have a comprehensive evaluation. Other parameters should also be included. This is mentioned in the guidelines that at least one from RA, one from RV should be reported.
So I think the audience must have got the message that at least we should measure the basal diameter, RV diameter, and should mention in our reports, apart from TAPSE, RVSV, and as he said, RA area should be done. So we should also improve our eco reports, and that's what we are here to discuss. What are the latest recommendations? And I'm sure everyone must have got it. So thanks once again, Dr. Rahul. And I think Dr. Rakesh Gupta. So now, the showstopper is coming.
So I must apologize to Dr. Rakesh for the delay.
He must be clearing off his patients by now.
It's all cleared now. Don't worry about it. It's all clear. Thank you. Thank you very much.
So
it was
now
such a nice thing. Like I could finish my cases completely right now.
Yeah.
Just last one is gone.
Yeah.
So I'll continue. And I say rightly, Rahul Malhotra rightly said, right heart always.
Yes. True.
And beautiful presentation, Rahul. Amazing. Like the way you put it today, and especially taking into the new guidelines which is just published. Even I had gone through them completely.
And I tell you honestly that he told me about this, and I incorporated after that into my own presentation. So thanks to Dr.
Excellent.
Rakesh.
Like
अच्छा, मेरी presentation का कुछ नहीं है.
नहीं, आपके तो मैं हमेशा से ही शुक्रगुजार हूँ कि आपकी वजह से हम इस प्लेटफॉर्म पर आए और आप इस प्लेटफॉर्म में हमने राइट डायरेक्शन अब पकड़ी है. अभी तक तुम लेफ्ट डायरेक्शन में थे.
Thank you. अपने आप ही ले लो.
It's all because of you. There's nobody else who's behind all these programs.
Thank you.
And we are so happy that this is going very well. And it's amazing, like people, what they are thinking now. Look, these, if you would look carefully, all these things they were right thumbs. They were not left thumbs.
Yes. Right thumbs. True. Correct.
So let me start with my presentation, and I hope you are able to see my slides.
Yes.
I'll be switching over between one case to another one. I have tried to make it as practical as possible. And this is one of the amazing technology. Many work has been done on this, and I've tried to collect many cases, and quickly I'll go through them. Before I start talking about all these cases, I just say, like, apart from Indian Academy of Echo, we do run these teaching programs in of Echo, and I could see Dr. Pavan Kumar Agarwal from Shahjahanpur. He is the IMA president as on today, sitting right over here. And at one time, he was working with us at Sundarlal Jain Hospital as a resident cardiologist, and now he's looking after the entire UP. And we are thrilled to see you, Pavan, over here. That's the most important thing.
Nice to see you, sir.
Yeah. And second important thing is everybody's.
I am credited with the longest touch with you. I think.
And your next door neighbor is one of the oldest student, just a few blocks away. Dr. Srivastav in Shahjahanpur. Anyway,
Yeah.
so this is really truly a happiness. Like many people are shifting over to and looking these programs. All credit goes to Dr. Hansa, Rahul, and Rohit Tandon. Then Vivek Sulere, like the new generation which is coming up gradually over a period. We are beaten out, burnt out generations. So younger generation is coming up very faster, and that's a really an amazing and good thing. Sis.
Old is
So look,
still gold.
yeah, but gold is now scarce and rare.
Gold is very expensive.
No, scarce and rare. It's getting scary, like people say it's 2 lakhs rupees, 5 lakhs rupees. So it's getting scaring every day.
Scary. Yeah.
And now I could see another one young person with a white mustache, half black, half white. And really they have grown up. They have outgrown the hairs on the head. Varesh Nagaraj Singh sitting over here from Devariya. I've seen you, Varesh, after many years, many, many years. So that's what like amazing things are happening. Anyway, let's move on to this. I said, when do we do this agitated contrast saline echo? So you have to have a vision. Like at what time, and that what vision is this slide is. You don't look at an echo just because of this slide. Look, the picture behind this slide is different. So many people have talked about right heart. Whenever you see RVRA, they are dilated. Just think of it. If you can't find anything, the contrast echo comes in handy. So we moved on from ages when we were doing just a basic of a color Doppler, like this steam engines. We went on to electrics, and finally, look, this is what is roaming us on today is a Vande Bharat and multiple trains, and that's what the technology as on today is. Now, how do we do this study? The first and foremost important thing, look, we have two syringes joined together with a three-way cannula and connected with a infuser or cannula into the skin. And then we take about 10 ml of a normal saline in one syringe or 9 ml of a normal saline in one syringe and half ml another syringe and mix them up together to make bubbles. Look, this milky white saline structure is there. And then we push into this venous circulation with a broad gauge needle, and preferably this cannula is inserted either in between the wrist and the elbow or above the elbow if it's possible. Now, what are the various views and what are the conditions where we do it? Like we divide them into two parts, which I'm going to say in a few minutes. Detection of a shunts, which could be of many times, and second is looking at the RV site. So multiple windows are used in these. Like if you are looking for detection of shunt, commonly is we use AP4C view, and often other windows are used is PSAX and subxiphoid. Similarly, when we are using a persistent left-sided superior vena cava, we are using the subcostal, or the most important thing is just look at a plaques and put an M mode across this. What will happen? It will cut across RV as well as the coronary sinus. Then RVRA delineating subcostal window, improving TRJ's modified four-chamber view, improved pulmonary, where we look at RV outflows views or PSAX view. Then echo-guided paracentesis, always subcostal, and I've used often number of times, even the apical four-chamber view doing a echo-guided paracentesis when we're doing apical windows. Now the question comes, what is the complication or key risk? The complications are very rare, but it do happen. I can quote in my lab where we had a patient, a very interesting patient, which I'll share in a couple of minutes, unroofed coronary sinus. And as we gave the contrast saline, what happened? The patient went into almost collapse phase. The pulse dropped, the saturation dropped, the BP dropped. Why? Because these bubble went into the coronary and cerebral circulations. Then we can have a transient headache, pain at the site of cannula. Allergic reactions are very minimal because we hardly use anything in it. And system embolation if you are really pushing too much of air when you're mixing the contrast. Very good safety profile. absolutely no radiations, no chemical toxicity, and very rare complications. And where do we do it? That's the most important thing. We divide them broadly into two classifications: shunt study indication and non-shunt study indications. Let's look at what are the indication for shunt study. When we have a dilated RVRA, we can't see any shunt or a flow across interatrial septum. We think of a PFO, AST, or other pulmonary causes. Then detection of persistent left-sided superior vena cava. I'll show you the example. Unroofed coronary sinus with or without left-sided persistent SVC. Then VSD with PS and pulmonary artery hypertension. Like many people, they think we cannot use them in VSD. I can assure you we can use in VSD and PDA also. I'll try to show the examples. Then detection of aortopulmonary shunts with PH. And finally, the hepatopulmonary shunts, which is quite common as on today, unless until we look at them. Now, here is the algorithm. What we see is localized RVRA and pulmonary artery. Inject into the right arm. If it's localized to right arm, then it's normal. There's no shunting across it. If it's not, then it's abnormal. Now the question comes where it comes first. It first appears in LV. Then we have VSD with pulmonary stenosis or VSD with pulmonary artery hypertension. If it appears in aorta, then ascending aorta, AP window with PH. If it appears in descending aorta, coarctation of aorta with PH. Then if it appears first in the atrium, now it's which atrium it appears first. That's the most important thing. If it appears in left atrium immediately, then ASD with PS or PH or ASD PFO with Valsalva. Next comes is supra SVC to LA. And there it appears first in left atrium. Now it appears after few beats. Then the two important things happen. Either we are looking at hepatopulmonary fistula or we are looking at pulmonary artery to LA fistula. So if you are looking at a contrast, you should think in what abnormality I am looking at. So I can broadly divide this abnormality either LA, LV or aorta. Suppose I'm thinking of dilated RVRA. So at that time, I should be able to understand like it what conditions I'm looking at these kind of things. And this is algorithm chart with which you can, this is all devised by me. Like nothing was there in literature to look at all these kind of things. This is how I practice in my life. Now, this was injected to right arm, correct? If you are injecting a left arm injection and you see into the LA, then is left-sided superior persistent left-sided SVC with 2 LA. Unroofed coronary sinus we see in left arm along with right-sided structures. And that's where we see in right arm contrast also. Third is we inject to lower limbs. Then if you see a contrast in LA means if you see that IVC is connecting to LA, is a very, very rare condition and very rarely you can think of it when RVRA they are dilated. Now, non-shunt is quite a common in things which we are looking forward. We have seen many people now doing like what we did almost 20 years down the line. We have seen the interventional cardiologist as well as the ICU in charge is looking at the contrast in arms for their central venous cannulation. I can like recently I was working in a cath lab for one patient and we were trying to put a central venous line and the this interventional cardiologist was telling me, Dr. Rakesh, can you show me the SVC, subclavian artery or subclavian vein? And then what he very simply did, he just put an agitated saline into the arms, and we could see beautifully the contrast out there. Then otherwise, if we are delineating right heart borders and masses, RV wall thickness, intensifying, that's what we have been doing in our lab also. I'll try to show an example today, which I did just today for recording purposes. then improving the pulmonary trunk and arteries, and to look for any thrombi, like we were talking of a pulmonary embolisms. Little scary in pulmonary embolism because already patient has got low saturation, but this will help you, that will give you a filling defects. And guided pericardiocentesis I not used for pericardiocentesis, but I've used it in therapeutic purposes when a patient presented with shock with pericardial effusion. So let's see one by one example. Shunt study, that's what I'm going to show you. That RA to LA immediately, that's PFO with a shunt. So I'll be switching over my gears from one cases to other cases. And I'm not going to show you many clips of that. I hope you're able to see my pictures. This is first case. Look, in this first case, RV is dilated and there is evidence of a coronary sinus, dilated coronary sinus over here. Now you can go and see this picture again. Descending aorta is here. So you're seeing two aortas at the same time, and that time you should think always that coronary sinus is dilated. Function is normal LV, but look at RV, which is again dilated. Again, you look at RV-RA, which is dilated. And like something like a different picture. Husband is pushed aside, outside. This whole wife seen over here. Contrast, could see a TR-jet gradient. Color Doppler. Nothing significant. IS aneurysm, if you happen to see IS aneurysm, it's more than 1.5 centimeter of a bulge on the right-hand side. Subcostal window, same thing you can see over here. Now we are giving a contrast to a patient. This is a large certain contrast, and now see the bubbles are seen on the other side. I'll play this film again. Just be careful. Like there's some deterioration in the imaging quality, but I'll hold. Look at the bubbles came immediately a few seconds later on, and we could see a negative contrast over here, filling defect. And we could see some bubbles coming over here. And this is what the reverse or negative contrast is. As soon as I gave a bubbles, there was a filling defect in this circumstances. And you look, this is the aneurysm seen over here. So you gave a contrast on right hand side, nothing was seen on left hand side, and you could see a negative contrast over here, suggesting that there is maybe some amount of filling defect seen over there. Now you could see bubbles in a later on half at it. Now I'm going to show this slide again and try to stop where you start seeing bubbles coming out from this place. Filling defect, and suddenly the bubbles came. But we were not able to show where the bubbles came. And that we have to stop the film in between to show the bubbles. So normally the bubbles were coming through this interatrial septal aneurysms. Somehow I'm not able to stop it, but you could see a bubbles right over here coming through this interatrial septum. And that's what was PFO. And the detection was happening when we could see a mildly dilated RV-RA with a negative contrast. And with this, I can say carefully, look, aneurysm was present, negative contrast was present as the LA pressure were more than RA pressures, and the Valsalva maneuver showed reversal of shunt. So what exactly we were doing at this particular point was, now you can see a bubbles coming from here. What exactly did we do this? When we were doing this, we asked the patient to hold his breath. And as the patient holded his breath for a little longer time, the bubbles start coming from a right to left hand sides. Because when he was holding his breath, he gradually went into Valsalva maneuver automatically. If we ask him to do a forced expiration and hold his breath, what happens? The image disturbs completely. And that's how we were able to see a flow of bubbles from atrium right ventricle to left atrium side. So this is one study, and especially the diagnosis when it's correctly said that is it was aneurysm along with a flow of bubbles into the left atrium. So let me switch over my slides to another presentations. This is what we showed you a few minutes back. Okay. Now comes the another one. This was a 36-year-old lady presenting with the breathlessness for a long time. 4 echo done outside, they were all non-conclusive. And that was, we did an echo again, and it was really challenging for us. I'll straightway quickly go to the slides. Now, this is what was most interesting. This is the one image where RV, they are dilated. LVLA, they appears to be normal. This is with a color flow with significant amount of tricuspid regurgitation, and we could see some amount of color flowing across this interatrial septum. This is without any colors. Now you can see the RA which is dilated, RV which is dilated, interatrial septum is bulging towards left hand side, and this is Chiari network, nothing to abnormality as far as the structure is concerned. And this category tells you that RA pressure is more than LA pressures. We went to do the subcostal window also. This is LA, this is LV, this is RA, this is RV, this is RA. And even look over here, the RV, RA, they are bigger than LV, LA. TRZ gradient, we could see a TRZ gradient of almost 39 millimeters of mercury, which is little less to my point of view. But definitely pulmonary artery hypertension is present in this particular subject. Now, we gave a contrast to right arm. And look, this is a picture of a contrast to right arm. And we could see all bubbles, but not even a single bubble has crossed over to left-hand side. All right. Now we gave a contrast to left-hand side. Now you could see the bubbles have come all the way into LV, LA, and there is no bubbles on the right-hand side. So what does it mean by? It means by my right arm is giving a blood to right atrium, right ventricle. My left arm is giving blood to left atrium and right left ventricle. But how this patient is surviving without any shunt? And this is a follow-up picture of the same patient. The next few clips showed evidence of contrast in LV-LA first, and then there was a contrast spilling over to RAV and RA. And this is one the patient I said he collapsed immediately, became pulseless, saturation dropped down considerably, and now you can explain like the complication. They do happen. They do not happen because of any other reason, because these bubbles, micro bubbles, they went into coronary circulation, cerebral circulations. The cath lab data is very handy. Now today we are using all disposable catheter. Remember a time when we were using a non-disposable catheters. We used to wash them, sterilize them, reuse them, and number of times these catheters used to have bubbles inside. So whenever you used to hook with the patient, Like sometimes these bubbles used to go in coronary circulation. So what do we do is that time was we used to push in whatever we have, mafentin, and aggravate the blood pressure to a very high limits, adrenaline, mafentin. And we did the same thing in our lab and jack up the blood pressure to more than 220 millimeters of mercury. All these bubbles were gradually washed out and patient came out comfortably. Like couple of minutes, the BP came up, the saturation came up, the heart rate came up. So now the question is, what is the entity which we are dealing with? The answer is, now look at this diagram. This is a right internal jugular vein, right superior vena cava. This is left internal jugular vein. This is left superior vena cava. And this is persistent. And this is left brachiocephalic vein, which is present over here. When I gave a contrast to the right AM, it came into the right hand. So what does it mean by the brachiocephalic vein was absent? Correct? Now I gave a contrast to left hand. All of the contrast came to the right atrium. No, it did not come to the right atrium. It came into the left atrium. And again, there was no contrast seen immediately to right arm. It means brachiocephalic vein was absolutely absent. Now this contrast came to left atrium first. It means when this persistent left-sided SVC was draining into the right atrium, there were some holes which was present, which was at the level of left atrium. And this entity is known as unroofed coronary sinus. And this is all coronary sinus part is. And when there is an unroofing of a coronary sinus is present, these bubbles, they get into the left atrium first and later into the right atrium. Now look at the same thing I can explain you right now over here. The first thing is only bubbles in right hand. So my left brachiocephalic is not there. Then I gave a contrast to left hand. So I could see two aortas. Look, dilated coronary sinus as well as descending aorta. So my contrast came into the left hand first, and in couple of seconds it came to the right atrium, right ventricle. It means what? As soon as I gave a contrast in this patient, before coming to right atrium, right ventricle, this contrast because of unroofed coronary sinus was resulting to bubbles in the left arm, left atrium, from left atrium to left ventricle naturally. And then they came to the right atrium, right ventricle. So the diagnosis was unroofed coronary sinus, absent left brachiocephalic vein, and dilated coronary sinus. And this unroofed coronary sinus is a variety of interatrial septal defect. And that's how we could make a diagnosis. We went on to do a CT scan. Like CT scan is fortunately is pretty difficult in Delhi also, because majority of these people are radiologists, they are not cardiologists. So what I do, I often send these patients to All Institute of Medical Sciences to get a perfect report, and even their diagnosis was suggestive of unroofed coronary sinus. That was one example which was a good for patient, doctor, and for the audience also. Because for patient, diagnosis was made. Good for a doctor because the patient collapsed. If we were not have been like active or reactive at the time, we could have faced the catastrophe. And is a like amazing things when we do an contrast study in this subset of populations. So that was a very good example for unroofed coronary sinus. All right, let's move to my another presentation. This is similar to what I showed you a few minutes back. Now look at this plaques view. RV is not dilated. The plaques view showed there's a dilated coronary sinus over here. Why this coronary sinus is dilated? Now it's beautifully seen the coronary sinus over here. And once we see this coronary sinus, we went on to do a agitated saline contrast echo. First, I'll show you a right arm contrast echo first. Now we have injecting a contrast. We are getting a patient ready. And now the contrast has come to coronary sinus. The contrast has come to RV. Now the question is, at what times it comes to RVR? Now look carefully. The first contrast comes to coronary sinus and then contrast comes to RV. Look at it again now. One, two, three, four. Yeah, sorry. Only 4 cycle. I could see my. I have to stop. I'll take it back. Yeah. Now look this. Coronary sinus is filled up with contrast, but there's no contrast into the RV. Now, after a few seconds, now the contrast has started appearing in RV also. So it's a denser contrast with a contrast RV also. So first coronary sinus, then RV. Now think how this could be possible. So what exactly happens is, now this is same picture, right subclavian, left subclavian, brachiocephalic vein. Now injected into the right arm, it came into this right arm and right arm into the right atrium or right ventricle. No, it did not come into the right atrium and right ventricle first. It went into through this into the left coronary sinus. So what does it mean by? It means by the right subclavian vein, before sending a blood contrast into this right atrium, right ventricle, through brachiocephalic vein, it is sent through the coronary sinus into the coronary sinus and suggesting that persistent left-sided SVC is present. Correct? Now, let's give a contrast into left arm. Look, the same thing is happening. Contrast in first arm first, and then later on into the RV. So as soon as you gave a contrast in the left arm, the contrast has come to coronary sinus, and later on this contrast has come to RVR. And if you really ask me, this picture should be a little different. The angulation should be different in the sense that left vein, subclavian vein should be a little lower as compared to the picture. So that the contrast first appears through this brachiocephalic vein. It will not go up. It will come from brachiocephalic vein, come like this and go to the coronary sinus rather than draining into the right superior vena cava. And this classically tells you that we are dealing with left-sided persistence of superior vein, left-sided SVC, along with dilated coronary sinus. And that's what the importance of abnormality. One indication I said when RVRA dilated. Here my RVRA, they are not dilated, but I have a dilated coronary sinus. Normally we do not see this coronary sinus at all. It's a tiny structure which is hardly seen over here. So that's what an unusual example. And we did the same thing in RVRA. In contrast in right arm, then contrast in left hand. And answer was virtually the same. So what diagnosis, if you look at this is vein is persistent, but the angulation of vein is like right superior vena cava draining through this brachiocephalic vein to persistent left-sided SVC. And that's how we coordinate. Suppose if I were given a contrast to right arm, it has come only to left coronary sinus and then to right atrium. And if I give a contrast to left hand side, the same thing happens. Then it means I have got an absent left-sided RVC, SVC. I hope you understand. Let me revise. Like left-sided contrast I gave first, it went and opacified the coronary sinus and then the RA. Normal phenomena, dilated coronary sinus. But at the same time, I'm giving a contrast in the right arm. It does not come into the RV, RA first. It what goes to the brachiocephalic vein 2, left-sided persistent SVC, then to coronary sinus, and then into the right atrium. So either there is shunt between these two, like unroofed coronary sinus, or this is absent or suggestive of absent right-sided SVC. Let's move further. I'll just try to show you two more cases, and then possibly it's like too much of utility is amazing. Like I can tell you there's so much of a utility. This is what I was talking about. A young man, 28 years male, working in the farm, suddenly developed some blunt injury from a so-called fan blade of the pump. When we looked what exactly are we dealing with, and the patient came to collapse at the hospital. And this is what exactly happened. There was no cover on this machine. And behind this is a fan kind of a thing, which is attached behind this cover. And this fan is screwed with the screws. So they become little loose, and this ran away when this motor started running. And what exactly did? It came and hit to a person working in the farms. When he came, he was cold, clammy, pulseless, BPLS, JVP was raised, SGR was positive, no pedal edema. Very feeble heart sound was seen, and the abdomen was firm to hard. Generalized tenderness was present, bowel sounds are present. There was nothing significant as an ECG, chest X-ray, ABG, arterial blood line shows blood pressure of 60 millimeters of mercury, CVP 20 millimeters of mercury. Now, this is an echo of a patient. Now, my cardiologist says, my surgeon says, Dr. Gupta, can you tell me like where is my patient, like where he has got developed a rupture of the heart? I said, I can show you a rupture of a heart if it's on the right side or in the right side of the heart, but not on the left edge of the heart. So what we did, this is a picture of a patient. Look at the time in the midnight. It's almost 11 o'clock in the midnight. A call had come. Not a call. In fact, I was on a rounds and he said, let me show you. So what we did, we did a subcostal window, and this is subcostal window. You can see all pericardial effusion all around. This is all pericardial effusion all around. So once we have a patient which is a collapse and we did an echo showing evidence of pericardial effusion, the only thing which is present in the mind is some dent, some rent in the heart. So this is all subcostal window showing a pericardial effusion. Follow nothing significant. This is the amount of pericardial effusion, mild over here. And now what we did, we gave an agitated contrast saline to this patient. As soon as we gave an agitated contrast saline to this patient, look, this is all become opaque, hyperechoic. Now let me show you a picture, previous picture and this picture. Now this is a previous picture of pericardial effusion in the 4-chamber view. This was 3-chamber view. And when we gave a saline to this subject, now look at this picture of 3-chamber view. You can see the now bubble seen over here. Similarly, you can see this is all opaque now over here. So we were sure that there is some rent on the right-hand side of the heart. And this contrast saline gave a very perfect idea what exactly we are dealing with. Now the cardiothoracic surgeon opened the chest, and you know what he could say? He could see a pericardial effusion with possible pericardial tamponade. That was our diagnosis at that Sunday midnight. Cardiothoracic surgeon was on leave. What to do next? We called a regular surgeon who worked as a cardiothoracic department in a senior residency. And now this guy, when I told him, he said, you tell me just whether it's LVLA or RVRA. So contrast gave us the answer, and we use this agitated contrast saline. Now this is a clear-cut picture which I was looking forward. So three-way cannula, 2 syringes, 10 ml saline, 9 ml saline, 1 ml of air, and we injected inside. And another pictures we take. Now you can see a contrast very clearly in this pictures again. And look, we are working at 11 o'clock almost in the night. Now we are confirmed. What are we dealing with? My surgeon opened the chest and he could found a dent and a rent in the right atrium. Now the question was how to seal it. And we, at the time, we were working primary care hospital, primary care cardiothoracic surgeon, primary care echocardiologist. Imagine what we could have done at that time. Anybody would like to say. We had no bypass available at that moment. We were pushing fluids, whatever we had. Anybody can think. We saved the patient, I can tell you that. And we do not have anything. The jugaad works. I said, let's put a Malachite catheter inside the right atrium. We put in a Malachite catheter inside, inflated the catheter, and coolly pull it up. And then we took a pursing suture against this rent, and we stabilized the patient by taking a pursing suture, pulling them a little bit up, and that's how we could stop the bleeding first. And this is what we were doing without any support. Lot of saline, lot of blood, whatever we had, we were giving, but it was oozing like anything. And after a few minutes, when the patient stabilized, his BP became 60 to 70, saturation started stabilizing down. And then we gradually pulled out the catheter and closed with a pursing suture, which we had taken just a few minutes back. And that's what we said when we utilize this technology of pericardial effusion by contrast echo, diagnosis in the right pericardium through a rent into the right atrium. And this Malachite's catheter was there, and that was it classically said Indian jugaad with echo. And finally, the patient stabilized, went home happily, and the hospital started inquiry against us, what the hell you were doing last night in the hospital. But we could save this patient with this innovative technology of agitated saline contrast echo. Just I wanted to show you this particular example. So not only identifying the RVRA, identifying the pericardium when the fluid is blood and blood is coming to the right atrium, right ventricle. All right. One or two more is almost 11 o'clock. Everybody must be tired.
Except you.
No, I'm not tired. Don't worry. I'm still alive, you know.
Yes, no, you're still the same with, teaching with the same energy.
Yeah, because this is, it's charging my batteries. So this is 2-year-old boy presenting with cough and breathless for more than 10 days. Look at his X-ray chest, multiple opacities in the X-ray chest. And this is an atrial tachycardia at that particular moment. There was T-wave inversion V1 to V3, not significant. Everything was fine. And we did an echo to this patient. Look, RV array appears to be a little dilated in this subject. And look, the most interesting thing in this patient was we could see the pulmonic venous flow, significant pulmonic venous flow, almost a velocity of a meter per second. And right pulmonic, that was almost normal. So there's a gross differentiation between right pulmonic artery and left pulmonic artery. And I wanted to show this. Look, there was a very slightest doubt being RVRA, they are dilated. 2-year-old child, like not significant of a things, but we could see this, there's something wrong which is going on. Well, what we did agitated contrast saline echo. Now you could see a bubbles coming from where? The bubbles are coming from the left pulmonic veins. If you look carefully, I can't give you a very good picture than this. Look, the direction of bubble. I'll try to stop you somewhere in between. Look, the bubbles are coming from left pulmonic veins. Well, very quite clear. There's something AV malformation or shunt in the left lung. Multiple causes. I'm not going to talk about the causes as on today. Right now, a lot of things are happening. So we made a diagnosis of contrast enhanced echocardiography. And with this, we could say that there was AV malformation. Patient was treated accordingly, and we went on to do a repeat study after a few weeks. Now, let me just show you that repeat study. Like I couldn't load it. Reena has given me up today. All right. So what we did a repeat echo after 6 weeks. Look, this is a repeat echo after 6 weeks. Same patient. Now, if you look carefully, this intermittent septum has started bulging toward right hand side. And now this flow is still present, but definitely less as compared to before. And when we did a contrast study in this patient, now look, this is before and this is afterwards. Now you can see the flow of intensity in the left pulmonic vein and a flow of intensity in the left pulmonic vein after 6 weeks. This is left pulmonic vein after 6 weeks. That's a comparison. And then we did a contrast study. Now, this is the previous one, and this is the later one after 6 weeks. There's no shunting at all from the left pulmonic vein. The flow, which was almost 1 meter per second, has gone down to 45, 47 centimeters per second. Almost normal. And if we compare this chart, before and afterwards, right atrium, mild elevated, normal, right size function, normal, pulmonary artery pressure, normal, right pulmonic vein flow, normal, left pulmonic vein, there was turbulent, but normal in follow. Left pulmonic velocity was mild, significantly increased. Now it's normal. Flow asymmetry, left versus right, present and absent. Delayed bubbles was present in the first study, no bubbles. AV malformation was suspected at the time. Now it's completely ruled out. And abnormal flow had complete resolute over a period of time. And look what we were dealing with. There's this new 2 years old child. We were looking at what? The most important part in this child we were looking for AV malformation because of secondary reasons like infective pathology. And now I'll go back and show you what are the basic causes for this is. And one of the causes, of course, in this subset of patients is when we have is pulmonary AV malformation, where bypass allowed deoxygenated blood to go to direct to the venous system, causing right to left shunt and reduce oxygen saturation, but not always. And here is the most important thing is these pulmonary AV malformations, they are like congenitals, hereditary telangiectasias, hemoptysis, cyanosis, paradoxical emboli, percutaneous embolizations. But for the first time, I can repeat, like they were happening because of infective pathology. And that infective pathology disappeared, this flow disappeared completely. And we could make a diagnosis without any CT scan. We did not get the CT scan done for this patient. So this is the power of echocardiography, especially when we are talking of. So many examples are there. Like it's a long time. Like everybody must be tired because that's what we have shown you over a period of time. And let me complete my lecture. That is all important. Give me a second because so echo does make a lot of difference when you're doing in a clinical practice. You have to put your head in everything together to make a diagnosis. I just could show you 4 cases. There were total 8 lined up today for evaluations. And I just want to show multiple, what are the other things which we can do. So we were looking at a shunt study indications, then right arm to left arm, right arm to immediately, then dual arm when we could see left-sided SVC, left-sided RVC, then mixed pathology. This is pulmonary AV malformation. We could not show it today. Left-sided SVC with pulmonary AV malformations. Then unroofed coronary sinus, I was able to show you. Then we have a PDA with PH. If it's 11 o'clock, I'll not be able to show it. Aorta pulmonary malformation with pulmonary artery hypertension. These are all recorded with us. And then no shunt study. I showed you a Malika catheter in our heart. And other examples for this particular examples are when we do all these kind of things, the non-shunt studies were just a second. I showed you these examples like delineating right heart borders, intensifying the TR signals when you have difficulty in estimating RV systolic pressures, pulmonary trunk for thrombi. And before I stop sharing my slides, one more example before we close, and this is very interesting what we did on our practice. Everybody must be tired, but let me just quickly show you one or more example, then we stop it completely. And this example is very interesting example in clinical practice. Can you see the slides now? So this is subcostal window where LA, LV, RV, RA. There's nothing which is dilated over here. Now the question comes, this child has come, normal presentation is like PDA from descending aorta to pulmonic artery. That's a normal structure what we see. What exactly happened is, now this patient has presented to us with dilated RVRA. Look, this is dilated, this is LVLA. And now the classical thing is, if you look at this short axis view, eccentric index is both more than 1 in systole as well as diastole. And with every systolic contraction, the interventricular septum is bulging towards LV. And when we did a short axis view at pulmonic artery, there was no flow which was seen from descending aorta to pulmonic artery. And then we thought, let's do a contrast echo for this patient. So we went on to do a contrast echo for this subject. And now look at the contrast. In short axis view, this is aorta, this is RA, this is RV, this is RV outflow tract. And this is pulmonic artery, right pulmonic artery and left pulmonic artery. But there is no PDA. And when we put in a transducer into the descending aorta and the abdominal aorta, we could see all contrast seen in the abdominal aorta. So can you make a diagnosis? And that's what was a challenging. Now the question is, this patient has got a significant pulmonary artery hypertension, which is suprasystemic. It means RV pressure is more than LV pressures. If RV pressure is more than LV pressure, and look, there is some amount of turbulence seen over here. If the pressure is suprasystemic, pulmonic artery, the descending aorta flow will not come back to pulmonic artery. The pulmonic artery flow will go to the descending aorta only. If there is some shunt. And when we gave us contrast saline to this patient, all this shunt had gone to descending aorta. And where do we see a descending aorta? We see a descending aorta to the pulmonic artery, descending aorta. And we could see a shunt by putting a probe in the abdominal aorta to which is shunt. And we could detect this patient as having a PDA with reversal of flow. And that could be possible only with a contrast echo. I don't say that's not possible without CT scan, but it is possible with contrast echo. And our diagnosis was perfect. Unfortunately, by that time, patient had already gone to Eisenmenger, where nothing can be done. His pulmonary vascular resistance was almost 5. And believe my words, I'm not exaggerating. What we did was, like, this lady was roaming around with breathlessness. Everybody made a diagnosis of PPHNR, primary pulmonary artery hypertension. So that is the power of a contrast echo in day-to-day practice. I can show you aortopulmonary window with pulmonary artery hypertension, where the blood is going from pulmonary artery to aorta. So finishing up with this slide presentation, one large slide just I wanted to show and stop before it. These are all indications where we use it, especially for TR jet gradients, when pulmonary artery pressures are pretty high, and pulmonary thrombosis. I can show you that example, a couple of more, which is still possible. So in the last, I would just say that this is one modality which is excellent for day-to-day practice. And now this is the time for dinner. So if you're fond of a drink, if you're fond of a hot food, this is what you can utilize in India country. And if you're working in a village, like, this is how you can live your life. Nobody is going to tell you anything. All right. Good night. Thank you very much for a patience listening. Great.
Thank you, Dr. Rakesh, for this elaborate.
I know it's elaborate because this is amazing thing happens when you really spend time.
And so let me just, give the word of thanks to everyone participating, staying back till late. And
Sir, one question.
Go ahead, Vinesh.
Sir, in the reversal of flow shown in PDA, what was the Doppler pattern through the PDA?
The Doppler pattern was only forward towards, because we couldn't see any Doppler pattern across it.
Achha.
The answer is, if you put a sample volume at the pulmonic artery, the flow would be increased, no doubt about it. Then you take your pulse wave to the right pulmonic artery and left pulmonic artery after the bifurcation. You will find more flow going to the left pulmonic artery rather than less flow going into the right pulmonic artery.
Achha.
But there will not be any reversal because the pressure are suprasystemic.
Acha.
Look, and we could see number of, like I couldn't show you today. I can tell you that we saw VSD shunt with pulmonary artery hypertension.
Yeah.
Aortopulmonary shunt where the pulmonary artery pressures are very high as compared to aorta because they have to be suprasystemic, same way that PDA is.
Okay.
All right.
Right,
Hansa, we
sir.
can close it down. It's almost 11:30. My
Yes,
volcano
yes.
sitting at home.
Yes, it is going to phato.
Yes. I told you yesterday, like we were traveling from New York to Delhi and Los Angeles to Delhi. And there was snowstorm outside and then volcano inside.
Yeah.
And my wife was cursing me, you took a wrong flight and you were coming from Los Angeles to New York, New York to Helsinki, Helsinki to Delhi. I said, snowstorm inside and a volcano inside could stabilize both the things together. And the plane flew off right into a snowstorm. The pilot was so gusty, the wind was flowing along with the plane in the same direction of flight. So he just took off the flight. So even volcanoes are sometimes useful, to silence the snowstorms.
Yes. And when you are traveling, then something like this has to happen.
Yeah, it always happens, man. The boy, like the life is such the